Good afternoon, everyone. Good afternoon. I'm glad to see you're here and not at the fair, but maybe. I'm Bill Hoagland, Senior Vice President at the Bipartisan Policy Center. I know the word bipartisanship in Washington sounds a little strange sometimes, but I can assure you on this issue there is bipartisanship, led largely by your senior senator, Senator Grassley, as he's working with his ranking member on the Finance Committee, Senator Wyden. I first want to thank Unity Point Healthcare for your sponsoring and this discussion this afternoon and for this beautiful venue in which we will have this discussion. And I particularly want to thank Sabra Rosner, Vice President of Government Relations and Public Policy, and Ashley Thompson, Director of Government and External Affairs, both here with Unity, wherever they are. Thank you very much for this. Also, I think I want to thank Eric Kubin. She's with the Iowa Health Association, and she's arranged for our task force, that we'll talk about in a minute here, where we're out at Knoxville Hospital and Clinic this morning. It was an interesting discussion. Before I introduce your senior senator, who needs no introduction to Iowans, certainly, maybe I should introduce you a little bit to the Bipartisan Policy Center and what this is about. The Bipartisan Policy Center was established about 10 years ago by 4 former majority leaders of the United States Senate, all who worked with your senator. They were 2 Republicans and 2 Democrats. Senator Bob Dole, the late Senator Howard Baker, Senator George Mitchell, and Senator Tom Daschle. I find it interesting, they were all from rural states, Kansas, Tennessee, South Dakota, and Maine. We don't usually think of Maine as a rural state, but it is extremely rural. The Bipartisan Policy Center is a 501c3 organization. Yes, sometimes thought of as a think tank. I like to think of it as a do tank. We actually try to carry out our recommendations and policies going forward. About a month ago, with the support of the Helmsley Foundation, we launched a task force of leading experts to help address the challenges that are faced by rural communities in the delivery and access to quality health care. The task force is led by one of those founders, Senator Daschle from South Dakota, and Senator Olympia Snowe, former senators, Snowe from Maine, and 2 former governors, Governor Musgrave of Mississippi, and former Governor and Secretary of Health and Human Services, Tommy Thompson of Wisconsin. That task force is starting to meet. We are very pleased that 2 of the task force members have joined us today for this discussion. Dr. Jennifer McKay, stand up and let everybody see you, Jennifer. She's with Avera Health, an integrated healthcare system based in Sioux Falls, South Dakota, serving South Dakota, Minnesota, Iowa, Nebraska, and North Dakota. And Dr. George Benjamin, he's the Executive Director of the American Public Health Association, formerly Secretary of the Department of Health and Mental Hygiene at the state of Maryland. Finally, before we turn this over to the chairman, we are particularly pleased that Walter Panzinger, a trustee of the Helmsley Foundation, has joined us this afternoon, along with Mitch Krebs, the foundation's Director of Rural Health. I should note that, I hope I'm not revealing anything I shouldn't, that they both met with your governor this morning on issues surrounding our discussion today. Walter would like to make a few remarks. His background is he's the grandson of Leona Helmsley, a paramedic, a firefighter, a law enforcement officer. His work has led him to direct the foundation to focus on the betterment of the lives of those underserved, which has resulted in the foundation's desire to focus specifically on rural health care, particularly here in the upper Midwest. So, Walter.
Great. Well, thank you for such a warm introduction. It's really wonderful here to be back here in Iowa. Like you alluded to earlier, we did have a great meeting with Governor Reynolds this morning. And I really have to give a shout out to the governor and really thank the governor, because she really understands the challenges of rural health care. And that's special to have such a great potential partnership going forward. I would also like to give special thanks to Senator Grassley for hosting today. This is wonderful. I thank you for being here. I thank you so much for your almost 50 years of public service, being there for rural states like Iowa, being there, being the voices for the underserved people here in Iowa, in rural America, and bringing attention to this huge need of rural health care and to level the playing field. Because at the Helmsley Charitable Trust, a little bit about the trust, we believe that your zip code should not determine your health care outcomes. We believe that if you choose to live in a rural setting, that your access to health care should be the same as your urban counterparts. And we're doing that. We're trying to do that and level the playing field through this program. The Helmsley Charitable Trust is a private foundation who has committed over $2.5 billion to philanthropy over the last 10 years. To date, the rural healthcare portfolio has committed over $400 million for rural healthcare only in the upper Midwest. When we say the upper Midwest, we focus in the states of Iowa, South Dakota, North Dakota, Nebraska, Minnesota, Wyoming, and Montana. So with these grants, and I should say Iowa alone has been a recipient to over $30 million just in grants in Iowa alone. But these grants have provided a variety of items to rural healthcare to help level this playing field. For everything from CT scanners to X-ray equipment to digital mammography, now because of the Helmsley Charitable Trust, every woman is within an hour's drive access of digital mammography. We have leveled that playing field. We have provided Lucas mechanical CPR devices in every ambulance service in our 12 upper Midwestern states, comprehensive cancer care, remote robotic surgery devices, just to name a few of the things. But we also recognize that small towns and rural hospitals may never have the same level of playing field and have the same level of care due to a variety of issues, from lack of physicians, lack of population, lack of specialty care. But at the Helmsley Charitable Trust, we're addressing that. We're addressing that through technology, through e-care, providing virtual emergency room physicians and specialty physicians at rural critical access hospitals. Virtual pharmacies. A lot of these hospitals in small little towns only have one pharmacist. In order to have 24-hour coverage of pharmacies in a hospital, you need an average of 4.1 pharmacists. That's just the math on it. And a lot of these communities struggle at just having one pharmacist. So we introduce programs like electronic pharmacy to reduce errors, to make sure that these critical access hospitals are compliant with all FDA guidelines of having a pharmacist review prior to first drug administration. So, and more recently, we just launched telepsychiatry, telepsychology services, because we recognize that mental health is a huge deficit too, and a huge area to address. There are so many changes that need to be made, and so many barriers. And that's why we support the work of the Bipartisan group and association to cut through the challenges, to address these challenges, and to form working groups like what we're going to see today, to talk, to address, and hopefully make some real changes to help every rural resident in every rural state across this great nation. Once again, I can't wait to hear what this panel says, but thank you so much for being here today. Thank you for taking part of this important discussion on rural health.
Thank you, Walter. And without further ado, let me introduce Senator Grassley, and thank him again, Senator, for you taking time out of your very busy schedule to meet with us this afternoon. And I want to thank his staff. I want to thank Evelyn Fortier and Jennifer for all the work you've done in helping make this doesn't happen just without staff work, I know. Largely because I've known the senator for 38 years. When he first arrived in the United States Senate, I know that he's constantly worked for the Iowans and this country on some very big, major issues. I have had the honor of knowing him for those 38 years for one reason, and that is because when he first arrived in the United States Senate back in 1981, he selected, or he was appointed to, I don't know which, the Senate Budget Committee, where I was a staff director for many years under the chairmanship of Senator Pete V. Domenici from New Mexico. So I got to know him over those many years, 25, 30 years that I was in the Senate also as a staffer. He has remained on that committee throughout his time, passing up, I should say, the chairmanship of that committee. I don't know why he would pass up the chairmanship of that committee, but for the Judiciary Committee and the Finance Committee, which are much more important committees. I'm impressed that he has not missed a single vote since 1995, and only then, 1993, I'm sorry, only then because he returned for some major floods that were out here, and that he is finishing up his, on this August recess, as I understand, Senator, your visit to 99 counties. So thank you very much, Senator, for all you do for the country, and thank you for being here this afternoon.
Before I read, I would like to say that Bill is an outstanding example of people who dedicate a lifetime of service, and he's still got a lot of his life left, and he may not be on Capitol Hill anymore, but those years he was on Capitol Hill, he was a perfect example of people that work long hours and weekends, and sometimes even summer breaks to help get things done. So I'm glad that we have such a large turnout here, and I want to say it's a wonderful afternoon to be with you. And I would start, as a couple other people have, by thanking our host at Unity Point for rolling out the welcome mat for all of us here today. We're here today to listen to the ideas near and dear to the hearts of rural America, more specifically, to discuss policies to keep high-quality health care accessible in rural communities. As we all know, rural communities are struggling to keep health care services available for their residents. According to a national analysis released earlier this year, 18% of Iowa's rural hospitals are at high risk of maintaining their existence. Today, we'll have candid dialogue on the unique challenges confronting our rural healthcare delivery system and the people living in our underserved communities. We're here to learn about the obstacles to care and ways to improve our systems of care so that rural residents aren't left behind. We're not here just to talk the talk. I hope to leave here today with a bipartisan blueprint that will serve as a vehicle to get more lawmakers on board in Washington. This is a good time then to thank the Bipartisan Policy Center for organizing this event in my home state. As a resolutions-oriented organization, this policy group have a deep leadership bench to help shape the debate and steer us forward. For many years, I worked on rural health care issues with Senators Tom Daschle and Bill Frist during their service as majority leaders of the United States Senate, respectfully, whether Democrats or Republicans controlled. We considered it a special mission to develop common sense Medicare payment policies that help isolated and underserved communities provide reasonable access to needed medical care as close to home as possible. Recently, however, I haven't had as much success building bipartisan support to advance targeted rural health policies in the Senate Finance Committee, probably due to the fact that at the grassroots of America, as well as in Washington, D.C., the country seems to be more ideologically divided. And if you expect Congress to represent the people of this country, I'm sure it's not surprising to you that Congress reflects some of that ideological divide. Whether we should or not, I think it's a fact of representative government. I welcome and encourage your advocacy to bring solutions to the table and work with me to build a coalition of the willing. With us today to help set the policy table is a group of well-informed practitioners and healthcare providers who report to work every day to serve and save lives right here in Iowa. These people will be introduced to you, but I thought I ought to at least acknowledge their hard work preparing for this forum. So I thank Sue Thomason, a Vice President and Chief Executive here at Unity Point in West Des Moines, James Ropeman, CEO, Pocahontas County Hospital, Don Bach, Director of Nursing at Buena Vista Medical Center, as well as a heart patient herself, and Dr. Jennifer McKay, a telehealth medical provider of Avera Medical Groups in South Dakota. Later this month, I will wrap up my 39th consecutive year of meeting and holding Q&As with Iowans in each of Iowa's 99 counties. Like most Americans, Iowans share a growing concern about the rising cost of prescription drugs, out-of-pocket health expenses, and surprise medical bills. Here in Iowa, we also face additional challenges that are unique to the less populated areas of the country. Employers, civic leaders, and hospital administrators routinely convey concerns about the uphill climb to keep hometown hospitals open for business. In addition to providing life-saving and primary care treatments and services, rural hospitals anchor the local community economy in many counties here in Iowa, meaning that in most of those counties, they may be the largest employer in that county. They often serve as primary employer and an important recruitment tool for employers trying to grow their workforce in the highly competitive labor market. In Iowa and other rural states, residents are challenged by geographic isolation, severe weather, transportation obstacles to see a doctor or nurse practitioner for even the basic primary care services, let alone receive the specialized medical treatments such as dialysis, radiation, or chemotherapy. I know that some of you are struggling to meet local demands to furnish a full range of inpatient, outpatient, and rehabilitation services. A different set of barriers confront hospital administrators who must meet the bottom line to make payroll and pay the bills to keep the lights on and the doors open. Low patient volumes and difficulties recruiting and retaining healthcare professionals present very big challenges in the rural health care space. There's also a shortage of mental health professionals in our rural communities. Maybe that's one of the biggest healthcare issues that crop up at my county meetings. People struggling with mental illness have trouble finding the necessary care and the necessary treatment. The downturn in the farm economy and catastrophic flooding affect Iowans across the state have further exposed critical shortage mental health services for Iowans who need them. Beyond the lack of access to specialty care, some rural communities are facing the stark possibility of having no health care services available in their county whatsoever. In the most plain-spoken terms, I'd like to share a message to these rural communities. Not on my watch. I'll continue to leverage my leadership assignments, champion innovative solutions, and raise my voice to education policymakers and lawmakers in Washington. And that simple message is rural health matters. It matters to a farmer in Audubon County, Iowa, whose pant cuff maybe got caught in a grain auger and requires emergency treatment to save life and limb. It matters to an expectant mother in Ringgold County who must drive hours for routine prenatal appointments and has concerns about getting to the hospital on time for labor and delivery. It matters to Iowans who are struggling to cope with the financial burden and emotional toll of flood-ravaged homes, farms, and businesses who have limited options to access mental health services. The good news is that we're here today having an important dialogue to discuss meaningful solutions and to find a path forward. First, let's review some of the policies that have already made a difference. More than 2 decades ago, I wrote the bill that created the Critical Access Hospital Program. These hospitals are a lifeline in our rural communities. I've worked tirelessly to expand, improve, and protect this program from the chopping block in Washington. In 2003, I also shepherded the landmark Medicare Modernization Act into law, which made dramatic improvements in rural health care. I championed several of its provisions to help rural hospitals achieve fiscal sustainability, including the low-volume adjustment payment formula, increased reimbursement for critical access hospitals, and the creation of the Rural Community Hospital Demonstration Program for what we call the tweener hospitals. Most recently, in February 2018, Congress passed a bipartisan budget caps deals which extended the Medicare dependent hospital and low-volume hospital programs for 5 years, the longest extension we've had for both of those programs in probably the 20 or 25 years of their existence. That same bill extended the gypsy floor, permanently repealing Medicare's therapy cap, and extended rural ambulance add-on payments, and paving the way for ambulance cost reporting. Now, by all accounts, these programs are pivotal policy instruments to help maintain access to health care in rural America. Thankfully, hospital closures that are happening in other parts of the country are not as common in Iowa. On the other hand, I hear problems for some of our hospitals in Iowa even after considering that statement. However, we must be proactive, and we keep on asking ourselves a very important question. What needs to be done today so that we're here to serve Iowans tomorrow? The good news is there are viable solutions with new models of care on the horizon. The delivery of health care is changing, and policy needs to keep pace with that technology. Telemedicine has tremendous potential to help solve many of the challenges confronting rural communities to maintain access to high-quality care. Consider a diabetic patient who lives 2 counties away from the nearest eye doctor. Skipping regular eye checks due to lack of access could lead to blindness. Vision screening via this type of medicine makes common sense. I've introduced a bipartisan bill that would allow rural diabetic patients to receive regular vision screening using telemedicine. Cutting ridiculous red tape and prioritizing telehealth services will grow patient volume, expand access, improve care, and increase flexibility. In the first 7 months at the helm of the Senate Finance Committee, I focused on reducing prescription drug prices, addressing the opioid crisis, and the pervasive scourge of methamphetamine in our communities, and fixing lax enforcement and substandard care at nursing homes. I'm confident that these priorities are shared by your health systems, your workforce, and patients in the communities you serve, because you see these things every day, whereas I talk about them from the standpoint of policy. With the new school year about to begin, I'll close today by giving you each a homework assignment. As you know, the soaring cost for prescription drugs has struck a chord in America. I'm asking each of the stakeholders in this room to help spread the word with your communities. My bipartisan Prescription Drug Pricing Reduction Drug Act, passed out of the Finance Committee on a bipartisan vote of 19-9. As chairman of the committee, I want to drum up grassroots support to keep up that momentum. As you might imagine, it's facing blowback from deep-pocketed special interests. My bill would bring sorely needed transparency to the drug supply chain. I've held 3 committee hearings this year to examine the drug pricing issue. Ranking Member Wyden and I exposed the cockamamia drug pricing system that virtually no one can make heads or tails of, let alone justify with a straight face. It's time to throw some sunshine into the process and hold big pharma and pharmacy benefit managers accountable for sticker shock hitting consumers every time you go to the counter. My bill also is good for seniors and taxpayers. According to the nonpartisan Congressional Budget Office that Bill Hoagland knows exactly how it operates, says that it would save a little over $100 billion and put a cap on out-of-pocket costs for seniors on Medicare Part D. With enough momentum, I'd like to see the President sign a comprehensive package bill of drug pricing reforms into law before the end of the year. That includes it would also include other bipartisan bills that have my support from the Senate committee that deals with health, that goes with the acronym HELP, HELP, and also from the Judiciary Committee that I serve on. Before I open up my time for questions, I would encourage Iowans in the audience to take advantage of this opportunity to listen, ask, and provide your feedback. As Iowans know, I take representative government very seriously. The team here from the Bipartisan Policy Committee chose to come to Iowa, and I'm glad that they did that. Let me make the most of it, or let us all make the most of it. They have good ideas to share, and with your input, they can incorporate your good ideas to form the work that they do, building bipartisan coalitions to get targeted rural health solutions across the finish line. And that's really the bottom line here, keeping rural healthcare systems financially viable to strengthen economic vitality, access to care, and our way of life in rural America. Now it's time for questions, and Bill's going to identify who can ask questions. Then that way you can't accuse me of wanting to avoid somebody.
And can I just ask, because I know as a staffer, Evelyn, and how much time do we have, because we're running tight here? Well, it's 4 o'clock now. Oh. 15 minutes. 15 minutes, okay. So thank you, Senator. Thank you very much. Questions for the Senator? Here we go, right here. First hand I saw. And there are microphones coming around. Please identify yourself. And as always, ask a question. Don't give us a speech if you don't mind.
Sure. My name is Dr. Anthony Melke. I'm a licensed family therapist and a professor at Mount Mercy University.
Can you hold it closer to your mouth?
Oh, sure. It sounds loud already. Is that better? Okay. Yeah. Dr. Anthony Melke, professor at Mount Mercy University for our family therapy program. You mentioned the crisis of mental health in rural areas, the exclusion of family therapists and licensed mental health counselors limits from Medicare spending, limits the amount of credentialed providers that are reimbursed by Medicare. In light of the current crisis, would you be willing to support the legislation to include family therapists and licensed mental health professionals in Medicare reimbursement?
You folks are well organized.
Thank you.
And that's a compliment, not a throwaway. Because I have that question asked. I'm always careful about adding anything to Medicare, considering the fact that it's in trouble by 2026, I believe is what the trustees say. Not saying that we don't do that on a regular basis. I've done that for 3 or 4 professions over the course, I think starting way back 25 years ago with direct reimbursement for nurse practitioners as one example where I've been involved, but I'm very cautious about telling you what I would support right at this moment for 2 reasons. One, for the reason I just gave you because of the potential trouble that lies ahead of us for the other, and then sometimes because being chairman of the committee, I think I ought to give other members an opportunity to lead the way. Okay.
Questions? This one right here.
I'm Sheryl Jones. I'm a pediatric nurse practitioner. I work with child health specialty clinics. We're part of the Department of Division of Child and Community Health out of the Department of Pediatrics and the Carver College of Medicine. We work with children and youth with special health care needs throughout Iowa. Our regional center, we're a statewide organization. Our regional centers are located primarily in rural areas. I'm out of Ottumwa. I serve southeast Iowa, do a regional satellite clinic in Mount Pleasant. Senator, I know you've been a supporter of Title V over the years, but I think to reinforce the importance of Title V funding for maternal and child health, not just in Iowa, but throughout the nation. But Title V really helps support a lot of the programs that provide services to women and children in rural Iowa. The other thing is with children and youth with special health care needs, they are a high-need population, and telehealth is a tool we are using extensively to serve those children. We do telepsychiatry, we do telenutrition, we're doing genetics now, we've got counseling for kids with autism, we are looking at neurologies doing things. So the support for that, but that also includes support for broadband throughout Iowa so we can make utilization of those. But I would urge you and the Policy Center to be cognizant of the importance of the Title V federal block grant in serving children and youth with special needs and women and children.
Yes, you made a statement I don't have to answer, but I'd like to tell you, and if you think I'm wrong on this, I hope you'll keep the microphone and tell me, but in 25 years or so that that I've been involved in this program as a member of the committee and otherwise, I don't think it's been very controversial. I think we've been fairly easy to get it reauthorized and everything. Do you see it having trouble in the Congress?
There's been times when I know in the president's budget, and I know the president just makes a suggestion, you guys around the budget. There have been cuts over several years and reductions, and so frankly, funding levels of Title V now are less than they were in the 90s in some circumstances. So yes, there's been support, but the need has exceeded the funding, which is true for so many programs. But no, you've been a strong supporter of Title V. We've sincerely appreciated that. Your voice has been important because I think you've made a difference on some years when we would have been in real trouble had you not been there. And I just wanted to reinstate the fact that we need that voice there because this serves an incredible, incredible resource, not just for Iowa, but for the United States.
If I could go back to the first question, there is an area where I'd like to be able to help you if you got some suggestions. It's not exactly the question you asked me, but on these, what we need for mental health is we need more practitioners to get into it. And if you've got any ideas on how we can get more practitioners into it, I'd be glad to help you with that, because the one thing that is very difficult for me to answer when I go around to my county meetings and this mental health issue comes up, well, first of all, some of it's at the state level, some of it's at the federal level. But the extent to which we can do something at the federal level it's difficult for me to say, we got such a shortage of psychiatrists and psychologists and other counselors. How do you get people into it? We don't force people to go into it. We got to encourage them to get into it. And the only way I know of doing it is for the underserved areas, or some sort of program for underserved areas. But you got to get people interested in doing it.
Additional questions? There's one back up here. Those of you out in the middle don't feel like the microphone can't get to you, because it can get to you easily. So.
Thank you, Senator, for your service to both Iowa and our country. Thank you very much. My name is Marty Guthmiller. I'm the CEO of Orange City Area Health System and the chair of the Iowa Hospital Association, also chair of the IHA Rural Task Force. I should mention also that James Ruttman on our panel today is a member of that task force. We will be bringing a proposal to you, a unified proposal on rural health in September to you in Washington. And I would like to ask you, what are the possibilities for moving a policy forward similar to your REACH proposal?
We have to, we hope to get that move forward, but we had a tremendous problem the way it was introduced last year and the way your task force has suggested it. By the way, is what you're talking about bringing to us in the fall, is that different than what I heard from the Iowa Hospital Association in March, or the same one? Yeah. Anyway, the financing, I believe your suggestion was financing at 110%, and the extent to which we tried that a year ago. We're trying to find a way of bringing more certainty to the funding to get a decent score from the Congressional Budget Office, and we still have not accomplished that yet, and we'll probably have to talk with you about something along that lines of what less than 110% or some other way of financing it could be, because it's something I really want to get done, where we give hospitals with low patient bedtime, in the average for most critical access hospitals around 5%. It's a very costly, the extent to which they want to maintain everything else that you can do for the rural communities, and on a voluntary basis give that up and serve the community otherwise for those emergencies and prevention and other services that can be delivered, I think is the only way we're going to keep a lot of health care in rural America. So all I can say is, if we can get something put together that we can get to support, then the natural place for it, to finally answer your question, would be in that end of the year bill that we have for rural health care. And that's where I'm pleading for the bipartisanship that we have had in the past on that so much, because we find it a little more difficult to get that sort of bipartisanship. Although when I ask Senator Wyden in our frequent meetings we have between the Republican and Democrat leaders of the committee, in other words, me, he and I, he did commit to helping us work on a rural health care package. And if that follows through. A year ago, though, when Hatch was chairman, we had the same commitment, and it did not work out that way. So I'm a little tenuous in promising you we're going to have that sort of a bipartisan package at the end of the year, but we still have to have something to present to the people one way or the other, partisan or nonpartisan, or bipartisan. See.
Additional questions? Here's one right up here.
Thank you, Senator Grassley, for the opportunity. My name is Brad Nahn. I'm with State Public Policy Group. We work a lot with rural development, economic development, but I have a specific question. Is how can we end surprise billing while lowering premiums and out-of-pocket costs? And specifically, I think there was a bill, Senate 1859 or 1895, I'm not sure which of those, but do you have a position on that?
Yeah, I sure do. I expect to vote for anything that Senator Alexander and Patty Murray come up with. That's in the other committee that I serve on. And Senator Cassidy has been the main introducer of that bill. And his approach has not been incorporated. I mean, the bill that came out of committee has a special billing section in it to stop that toward I said special billing. I mean, what's the word? Surprise billing. Thank you. It has a provision in it, but right now they're trying to work out the differences to satisfy Cassidy. And the main one is whether or not you're going to have arbitration like as you use in the state of New York, or whether the approach that is in the Alexander bill. And I think they can work it out, and I think it will save money. But I think you got to look at 3 aspects of saving money on health costs, which we started in January between the Alexander Committee and my committee, and then incorporating some things that came out of the Judiciary Committee to have the total program led mostly by the bill that came out of my committee to cut down on costs. These 3 bills need to be put together in one bill, and hopefully they will be. See.
There's one here, and I think we have time for just about 2 more questions.
Hi, Senator Grassley. Beth Townsend from Iowa Workforce Development. Workforce development in healthcare is an issue, and the Trump administration has been putting a lot of money into registered apprenticeship programs. Do you think there would be any appetite for creating grants that specifically focus on creating registered apprenticeships in the healthcare industry, like the Certified Medical Assistant Apprenticeship Program they have here at Unity Point, which is very successful, as is the CNA program at Broadlawns?
Okay. I don't think I have an answer to your question, except if it's a program to be announced on a nationwide basis, I guess I'd have to say, if you wanted to get it started, we should use a demonstration in a few states to, if it's something that needs to be done. And the workforce, I don't question the need for workforce development in this area, but the extent to which it's going to be done on a nationwide basis, I think you'll have to get it started on a demonstration basis first to see if the investment of money is paying off.
One last question.
Hello, my name is Lena Tucker-Reinders. I'm the Executive Director of Iowa Public Health Association. Thank you for taking our questions today. I appreciate your statement that rural health matters, and I would go a step further and say that rural public health matters. As you likely know, public health is on the forefront of population health and promoting health and through the programs and policies that generate health. And as you likely know, Iowa has the 4th highest rate of obesity in the state. We are seeing increasing tobacco rates. We have high levels of binge drinking among our state. And those all burden the health care system. Now, local public health is largely funded by reimbursement dollars through Medicaid and Medicare. They are limited in their unrestricted funds to impact population health and do those prevention programs and policies. And so I'm wondering what support that we can expect from you to support the public health component of rural health care in Iowa.
Well, I think, you correct me if I'm wrong, but I think you're talking about aren't you talking mostly about outside of Medicare and Medicaid, the appropriations that the federal government has for public health? I can't give you a specific figure, but assuming just before we left, we had the bipartisan agreement on spending for the next 2 years, and there's an additional roughly $70 billion each year for domestic programs. And I can't believe that hardly any domestic program isn't going to get a chunk of that $70 billion. But how much of it will go to public health? Not being a member of the Appropriations Committee, there's no way I could tell you. But it's a very basic compromise that we had to spend more money on defense than had to spend almost an equal amount on domestic programs. So that will up what we had this year by that X number, that $70 billion spread across, hundreds and hundreds of programs.
question, and then I have a suggestion, Senator.
Okay.
Senator Grassley, thank you for the opportunity. I am Dr. Priyesh. I'm a cardiologist here at Unity Point. I trained at University of Massachusetts for 7 years before I got the opportunity to come and work here.
Well, thank you for coming here.
I appreciate it. And it's truly been an honor to work in Iowa. Now, I got the opportunity to work here based on a program called Conrad 30, where 30 physicians who are trained in U.S. universities get to come to Iowa to work. And this bill is up for renewal. I think it's S948, and it's with the Judiciary Committee in the Senate. So what's your position on that?
Is that the Lee bill?
That's Senator Conrad's bill, yes. And Senator Conrad, by the way, is a member of this task force.
Yeah, but that's the same bill that Lee's working on for green cards.
Right.
Yeah. I think let me tell you, I believe the reason you're asking me this question is for 2 years, I held up that bill because I wanted some, I'd call it integrity provisions put into it so the program served its legitimate purpose. So then I worked those compromises out with the sponsor of the bill. And you would think, ye gods, Chuck Grassley's what's holding this whole thing up for 2 or 3 years. Then it'd pass immediately. Well, you know what happened? 3 or 4 other people come out of the woodwork that evidently I didn't even know about. And now they got problems with the bill. But I don't have any problems with the bill anymore, and I'm going to do what I can to help get it passed because all of the integrity provisions that I was working for the last 2 or 3 years has been incorporated in the bill.
Okay. Thank you, Senator.
Thank you, Senator. Just one quick comment, Senator. That bill you talked about, which was the bipartisan budget agreement that you passed just before the recess, does have in there an extension of the sequester. At our meeting this morning at the Knoxville Hospital Clinic reminded me that for critical access hospitals that are normally reimbursed at 101%, that's 99%. Rather than 110%, back up here, I'm a budgeteer, we're starting out slowly. It does seem to me that you could, for the purposes of that sequester, make it not applicable to critical access and be a small way to start to move to provide the kind of reimbursements that critical access. Think about it.
Sure.
Thank you, Senator. Let's thank the Senator.
And thanks to the panel for coming.
I'm going to now turn this over to our project manager on this, Marilyn Serapini, and our panel discussion here of these issues going forward. So, Marilyn, introduce your panel.
Okay, thank you very much, Bill. And we've already heard a lot from Senator Grassley. We've heard what's on your mind, and we've assembled a panel here today with the hope of bringing different parts of the rural healthcare system to you so that we can have a real discussion about a lot of the challenges that are acting as barriers to access to healthcare in rural areas. As Bill and others have mentioned, we have this task force that we are working on, and our task force will come out with recommendations for policy, whether they are legislative or regulatory, by next April or so. And we're lucky enough to have a couple of our task force members with us today. And right now we're in the information gathering stage. So we're delighted to see so many of you in the room today. We want to hear from you. We want to hear from the folks at the table. While our task force is focusing on everything, all issues around access, which have to do with, we hear about rural hospital closures a lot in the news, making headlines. We've already talked today about reimbursement and payments to support rural health care. Today we're going to specifically focus on workforce challenges, which is tied into all of those things I just mentioned, so I expect that they will all be coming up. Here's what we know. We know that rural health care challenges have been around for a long time. This is nothing new. But it is starting to gain hold as an explosive issue across the nation. The Secretary of Health and Human Services, Alex Azar, has recently decided to make rural health care a top priority. We know that it's always been a top priority for Senator Grassley and other members of Congress who are from rural areas. But now everyone is paying attention. The House Ways and Means Committee, which really is the counterpart to Senator Grassley's Finance Committee in the House of Representatives, has created its own workforce or task force to start working on these issues. We are starting to hear presidential candidates come up with proposals that focus specifically on rural health care. This is not typical. So we feel that the time is right to focus on the issue with the help and the support of Helmsley to really start to address some of these issues. So again, as I've said, we already know that there are challenges, and we know that there are workforce challenges. For every 100,000 people in rural areas, there are 40 physicians. That compares to 53 physicians in rural areas. But if we break that down and we look specifically at specialists, it is stark. For every 100,000 people in rural areas, there are 30 specialists. That compares to 263 specialists in urban areas. Recently, we conducted a survey of rural residents across the country. We did it in partnership with the American Heart Association. And while we surveyed adults nationwide, we also specifically bulked up our survey. We asked a lot of people, a lot of adults in rural areas of Iowa. And nearly half of the people in Iowa said that they believe access to medical specialists such as cardiologists, oncologists, gynecologists, was a problem in their community. So we have an extremely knowledgeable group of panelists with us today to talk about these challenges, and we want to talk about some possible solutions. So first to my right, we have Dawn Bach. She is a heart patient, and she's going to tell us her story, but also she is a nurse, and she's the Chief Clinical Officer at Buena Vista Medical Center here in Iowa. Next, we have Ed Friedman. He's administrator, and he's a physician assistant at Redfield Medical Clinic, which is a rural health clinic. And after I introduce everybody, we're going to get into what these different designations are. Down at the end, I believe, we have Dr. Jennifer McKay. She's Medical Information Officer at Avera Health. She's based in Sioux Falls, although Avera does have facilities here in Iowa. James Roatman is CEO of Pocahontas Community Hospital, and that is a critical access hospital. Again, we're going to talk about some of these distinctions and what they mean for the ability to get providers into rural areas and keep them there. And then second from the end is Sue Thompson. She is Senior Vice President of Integration and Optimization here at Unity Point Health. Sue also, she serves double duty because she is also a commissioner for MedPAC, which is the entity, the independent entity that advises Congress on Medicare policies. So with that, let's start with the problem. And I'd like to ask James to kick this off, but I want all of our panelists to weigh in because I think everybody is going to have something to say about this. What is the extent of the workforce challenge? Why are we, how significant is the problem in rural areas? Where do we see the holes and the gaps? And why are we seeing this? What is the cause? So James, perhaps you can start off by first explaining to us what a critical access hospital is. Senator Grassley talked a bit about critical access hospitals, but talk to us about your hospital as a critical access hospital, and then kick us off in this conversation about how significant this problem is.
Well, to talk a little bit about critical access hospitals, Senator Grassley did mention during his talk that almost 2 decades ago, he helped with that legislation to pass the critical access hospital program, in which I believe in Iowa we have 118 hospitals, and I think we're at 83 to 85 hospitals are a part of that critical access hospital program. And the biggest change with that program dating back to 2000 was that hospitals at that time that entered into that program were reimbursed on a percentage of their costs related to Medicare, Medicaid, Medicare percentages. And that process has not changed through the years. Recently, with the sequestration that was mentioned earlier, our 101% of costs now has changed because of that 2% to 99% of our costs.
And the sequestration is a requirement that there be an across-the-board cut in Medicare payments.
That's correct. Yeah. And even though there was some exceptions to that, critical access hospital program was not an exception to that rule. So, for instance, how it relates to our hospital and many of the rural hospitals, not only in Iowa, but across the Midwest and then West is, you know, for instance, as it relates to our hospital, we have roughly a 70% Medicare and Medicaid ratio at our facility, which means 70% of the people who walk through our doors are part of those two programs. So when that sequestration came into play, where we went from a 101% of our costs to 99% of our costs, we ended up losing 2%, which really was our margin, okay? So right now, as we sit, as our business goes, on 70% of our patients, we're set to lose 1% of what it costs to provide that service. And the joke that we talk about is, you can't make that up on volume, right? It's like if you were selling tires for 1% less than what you bought them for, you can't make up that gap. So the biggest thing, and Senator Grassley talked about that, is really what we're struggling with is the reimbursement model. For instance, our specific hospital in Pocahontas, we had more service or occasions of service this past year than we have in the last 5 years. That means we've had more people walk through our doors this year. So the volume is not going down, but the reimbursement is. And that's really, no matter if you're a physician or a hospital administrator, that's where the problems lie. I'm proud that the fact that we live in a rural area, and should we demand more or less care because you live there? We talked earlier, you should be able to get the right to that same care. I appreciated Walter's comments. Through what he was talking about, he understands the challenges that we face, and I appreciate the fact that he feels that just because you choose to live in a rural Iowa or rural Utah or wherever it may be, Montana, Minnesota, South Dakota, should your expectation of health care be any less?
So I'd like to open it up to other members of the panel here, and I'd love to hear what we hear all the time: workforce shortages, workforce shortages. What does that look like in the rural areas of Iowa and across the nation?
I think from a physician perspective, workforce shortages look like your patient calling you from the emergency department because they see your lights on in your living room as you're taking an evening off with your kids. And as we were sitting here, I was thinking about, we always talk about heads in beds for hospital volumes. The heads in beds that we need the patients we need to take care of, but we got to keep the physicians' heads in the bed so that they can go to sleep at night. The issue with workforce is, of course, with specialty care, as you go up the specialty pyramid, it gets very, very small. And somebody who grows up in an area in a rural community may not want to choose to go back to a small community because it is going to be stuff like a phone call from your patient at your home. And it's not to say that that's bad, it's just to say that it is somewhat different. The second piece is choosing as a physician to be in a space of being clinical as much as I can. As we talk about all of the reform, it's interesting to me, people said, well, you don't talk too much about legislation, but I talk an awful lot about the regulation around what I do. Physicians are the most creative, highly directed, driven workforce in the world. And in today's regulatory environment, we would never see something like open heart surgery be invented. And the reason we wouldn't is because the regulation, the protocol around taking that kind of a risk does not support what made medicine great 100 years ago. So for me, what I tend to talk about are rolling back some of the things that burden us. And when we were in Knoxville today, what really came out was how many people have to support things like reviewing the physician documents so that we can make sure that people believe what we did and that we don't get cited for fraud. So there is also an uneven balance there. But with respect to workforce, I think it really just comes down to how do you get your hometown kids to come home? And even better, how do you get people who maybe never were born here but would also like to live here, come here and stay?
Yeah. So how, let's dig a little deeper on that. How do we recruit and keep providers in rural areas? Do we need to home grow them all? Do we need to have some of their training cycle through rural areas so they get used to rural areas? We have a number of programs in place, and the gentleman in the back mentioned one of them to allow some physicians who train here in the U.S. to stay here, the part of the Conrad 30 law. And, but we have some loan forgiveness programs. We have some incentives to try to bring people to rural areas. So why are we having trouble recruiting? And Ed, I want you to weigh in on this too, because you're in a bit of you can offer a unique perspective. You're with a rural health clinic, which brings us beyond the physician perspective to physician assistants, and other clinicians. So I don't know, perhaps you'd like to start? Tell us a little bit about rural health clinics.
Sure.
and
Rural health clinics are a special government program that was passed in 1977. The purpose of the program was to reverse the trend of physician offices closing throughout rural Iowa and small towns, losing their access to health care. The deal was that if the rural health clinic, a special entity created by this program, which could be either run by a hospital or run by an individual provider, a physician, PA, or nurse practitioner, would employ a PA or a nurse practitioner half the time the clinic was open, then there would be enhanced reimbursement from Medicare and Medicaid. The other thing it did was to allow nurse practitioners and PAs to actually practice without physician being present and to be reimbursed by Medicare and Medicaid. That has been a very successful program with now 180 rural health clinics in rural Iowa in 73 of our 99 counties, matter of fact. Rural health clinics work closely with community or critical access hospitals. In fact, many critical access hospitals have rural health clinics to extend care not only in the town they're located, but also in the smaller communities surrounding them. As far as workforce, one of the things we do at Redfield, and Redfield is the only source of medical care, the Redfield Rural Health Clinic is the only source of medical care in the small town of Redfield, Iowa, which has a population of 835. We have students from the 4 PA programs in Iowa come to our clinic and participate or get their clinical rotations there that they're required to have during the year of their education. And we've also had nurse practitioner students there. There they learn the fun of taking care of people who are your friends and neighbors, like you do in a small town. Most of us from small towns already know that. I have to admit that I was a person who grew up on a farm outside of a small town, and then I was a combat medic in Vietnam. My mother and all 4 sisters are in medicine, 3 of them being nurses. My mother was a nurse too. But as far as for workforce, yes, expose them to rural practice. and include that in the education. That includes physicians as well as nurse practitioners and PAs. The other thing about nurse practitioners and PAs to keep in mind is that nurse practitioners and PAs can and often do make life more livable for physicians. In fact, I take the call. So I screen the calls and take care of the patient's problems before I contact my physician. And I only contact the physician if I need to do it. And I've been in practice 43 years, so very seldom do I have to contact the physician, because it's either the patient goes to the emergency room or can come into the clinic tomorrow, or they need to have an arrangement made for them to see a specialist. So other things as far as for, and I'm talking here a bit, but our loan forgiveness, extremely important, because physician loans, oftentimes $200,000 a year. PA and nurse practitioner loans are oftentimes $80,000. So loan forgiveness programs, especially supported by the government, are particularly helpful, or loan repayment programs. And then scholarships, the National Health Service Corps, those things all have proved to be quite useful. And revenue is still key to all of this. When you have a student at your location, you have a little less time to see patients, so a financial incentive to do that, such as Georgia did the income tax forgiveness program for preceptors. I think that would be very helpful. And finding rural preceptors is becoming a bigger and bigger challenge as we get more and more students that are interested in being nurse practitioners and PAs.
Mm-hmm. So Sue, I'd like to ask you to weigh in here. What do we need to do with the training of these physicians to draw them into rural areas?
You know, I'm of a mind that if we put our heads together, we can figure out how to tell a great story about life in rural America, including the state of Iowa. And that's a marketing challenge, which is, I think, one of the many variables that we need to weave together here to create a comprehensive solution. And I think we've touched on many of the variables here, which I really will probe here in a moment, but not the least of which are the comments that you made, which I love, and that's about taking care of our providers. And that, I don't know, requires policy, but it does require very thoughtful, intentional creation of an environment where our providers practice. So there's work to be done here outside the bounds of policy that I think I just want to call out and compliment your comments about the heads in the beds are also for our providers to take care of them. But I thought the statistics that you opened with were so evidentiary of the issue we have at hand, and really on a beyond rural. When you look at the number of primary care physicians in urban versus rural versus the specialists, and how those numbers really jumped, there's a reason why those numbers jump, and it has everything to do with these physicians, which, let's go back to when they're medical students, making decisions about what specialties they're going to do residency in. And they look at the debt they're incurring from undergraduate and medical school, and then they're looking at what can I make as a primary care physician who doesn't do OB, because these rural communities anymore, cannot support an OB practice, so I can't build OB into my compensation. They look at psychiatrists. While they maybe really loved psychology, they maybe even were a psychology major, but what does a psychiatrist make compared to if I do a cardiology residency, if I do an orthopedic residency, if I do any of the surgical residencies, my opportunity to get that debt down a whole lot quicker becomes very real. So my point in going through all of that, I think it's much earlier in the educational process that we need to get to these students, not only with a marketing plan for why it's great to practice in rural America, Iowa specifically, but there's an opportunity to do better from a compensation standpoint, because we have got to, from a policy standpoint, begin to identify this disproportionate difference between what we pay the cognitive specialists, our internists, our family practitioners, compared to what we pay our proceduralists is wrong. there's something fundamentally wrong. And I would make a case for a rural community, as James lives in Pocahontas, if he doesn't have primary care to build around, he has a really tough time to create anything that resembles acquiring connection to specialists, whether it's visiting specialists or it's specialists through telecommunications and telemedicine. Telemedicine, I'm so excited to hear you speak more about this because I personally think it's one of the nuts we have not yet cracked. I think it's technology that's way ahead of our industry's willingness to adopt it. And yet we have a whole generation of practitioners who are graduating and in the workforce who love technology. But there is something yet, and I'm anxious to hear you speak more, about us not being able to leverage that in the way that we could and should. So those would be my opening comments.
So, Dr. McKay, we've teed up the discussion for you to tell us some of the cool things you're doing in telehealth.
Sure. Well, the first thing I'd say is I was going to, if you didn't say the cognitive specialties issue, I was going to bring it up myself. At some point, somebody's going to have to decide to pay the people that think about the patients the most. And that are the internists and the primary care doctors. There's a lot of jokes in healthcare about internal medicine doctors. We are, in fact, the people who stay around the longest. We are the people who stay with the patient until they die. We have to get our arms around paying people more. When I'm getting paid $23 for a level 1 visit in a hospital on a patient who can't even get out of bed, that's a problem, especially when my orthopedic surgeon doesn't have to actually see the patient anymore after surgery. So those are conversations that are hard to have. It really does highlight, though, where telemedicine can be supportive and can be helpful. And as a hospitalist, what we've been able to do with our telemedicine services is do a couple of things. We've addressed the heads in beds issue by diminishing the number of calls going to a physician. We started it initially within our own group because we have people doing admissions all night long. We've actually extended our services out into Iowa. We were at Knoxville today and we're able to do that, where from 6 p.m. to 6 a.m. we have our people actually doing those admissions remotely. But it takes a couple of key things. One is redefining what a visit is. We have to understand that today's visit, with today's technology, with today's amount of data available for every single patient, maybe I don't necessarily need to be physically located in the same room with you in order to have that qualify as a visit. What's interesting about what Avera's done is that we have partnered with the Helmsley Trust, and they've had great faith in us to be able to establish a very large telemedicine footprint. It's interesting, though, that that's been able to grow because it hasn't been attached to the regulatory environment around which physician billing and coding has to happen at the point of documentation. And I can't say enough that it's been successful because people have been allowing the natural work of patient care to succeed using technology. The last thing that I'd really identify in terms of the telehealth is the ability to really look at these patients who take a lot of resources at the end of their life and to reach out to them where they are. We know in rural communities that when you have to deal with things like winter or tornadoes or floods or living 35 miles away, that you can't use the same kind of techniques to reach out to patients that you can in a more urban area. Having discussions around video visits at home, having discussions around working with our case managers and our care coordinators using telemedicine and technology has been really fruitful. And then the last thing that I would say is that our other areas of support, and we can't say this enough, there's a lot of physicians that work in our telemedicine hub, but there are also a lot of nurses to support the physician practice. And these individuals are critical to the work that we do because they're able to help and be available immediately to sites where, for example, I might be tied up doing something else. We can have our nurses and our experts. So all in all, I think from a telemedicine perspective, I don't know how I would be doing what I'm doing today without it. It's been a key part of the success of our organization. It's been a key part of how we've been successful using ACOs. And it's also very important to understand that we have probably saved Medicare a lot of money. We haven't probably made a lot of money on it. But because we have been committed to serving rural peoples, we have understood that we have to change our business decision and our work at hand. The good news is that because of the changing payer or payment environment, it's actually positioned us very well to function in those ACO type worlds.
Marilyn, if I could touch base on something that Sue, or both of them actually mentioned, from the pay differential. So this is our spiel when we're trying to recruit a family practice provider to a small rural town. So we're asking you to come and work in our community where for a short period of time, whether you're in the emergency room or in clinic, you are the cardiologist, okay, and you are the orthopedic surgeon, and you are the pulmonologist for that patient until we can get you to that care. And by the way, you're going to make this much money doing it. So, you know, Sue mentioned the fact about that difference, and it's interesting, and you wonder why. The hardest part isn't recruiting people to our communities. The hardest part is retaining them and keeping them there, because quite honestly, people get out there and, you know, when they're there for their visit, when you're recruiting them, you have community members involved, there's a lot of fanfare and stuff like that, and then when they're there and working, they realize that this is different than what it was the week that I was here visiting. And you're recruiting the physician, you're recruiting their spouse and their children and all that stuff. And it's important. And is it easier to have somebody that understands ruralness? It is. But if it isn't, it involves your facility, your staff, and the community in recruiting those people. You're placing them on this island with no resources. And when we talk about, the last thing I'll say related to that is when we talk about rural, you know, you'll talk about recruiting people to rural Des Moines, okay? We're talking about recruiting people to rural Redfield and rural Pocahontas and rural Sac City. There's a difference. There's a different degree of rural, and people don't understand that really when you're sitting in Washington or wherever and say, hey, we got people to Des Moines, you know, things are working great, or we got people to St. Louis, you know, that's pretty rural. That isn't rural, okay? That isn't what we're talking about today. So.
Okay, so Dawn, let's turn to you. You have a compelling story that's not only compelling in and of itself, but also gives us a great understanding of the need in rural areas for systems and pieces of the puzzle to work together. So tell us about your story, and folks who are in the audience, get your questions ready because we'll turn to you in just a moment.
Thank you. I want to tell you, I'm here today to talk about a success story between a rural facility and a senior facility hospital that actually saved my life. January 30th of this year, it was freezing, 22 below zero. I was feeling great. We were at a conference outside of the hospital with all the leaders from our hospital, about 34 people, and we were doing, the topic was joy in work. And we have a networking little breakfast before we get started. I happened to be visiting with our ER director at the hospital in this conference area, and all of a sudden I saw her head become two heads and then come back together. And I remember thinking, maybe I'm lightheaded. Did I have breakfast this morning? And then I remember thinking, oh, I'm not going to make this. And I remember nothing else. But the ER director and the people that were there tell me that I grabbed my heart and fell over, actually collapsed. They had no pulse, so they started CPR, continued CPR, looking for an AED, defibrillator. You know, we have several in different areas in the community. This conference area did not have an AED. But immediately when I collapsed, they call 911, and our police force always answers 911 calls, fortunately, because in a police car is an AED. They put the AED on, stopped the CPR, and then it said stop, analyze. It said analyzing, and it says advise shock. They shocked me, and they said I immediately sat up. And then I start to remember things again. The ambulance has arrived. They're putting oxygen on me. At this point in time, I really think that I've just fainted. You know, in fact, I kind of think they're making a little bit of a big deal about this. My one friend was just extremely emotional. But as I get into the ambulance, there's the EKG, that little heart rhythm monitor that you see, and I could see it clearly that I had what you call ST elevation. It's one of those little marks that just shows that you're having a heart attack. And And I turned to our paramedic that I knew personally, Kyle, and he said, oh yeah, yes, Dawn, you've been resuscitated, and we're gonna get you to Sioux City as fast as we can. They get me into the ambulance. They tier with the helicopter at a point about maybe 20 minutes from the hospital to get me there as soon as possible. As I land in the helicopter, they take me directly to the Cath Lab. And the Cath Lab is, for those of you that might not know, they actually go up your artery into that heart and look at which of those 4 coronary arteries aren't working. Mine happened to be it's called the LAD, the left ascending. It also is called in layman's terms the widowmaker, or in my case, maybe widower maker. They put the stent in, it was 99% blocked. They open up that vein or artery, and you can just see how that blood flows right to my heart. So I spend 1 day in ICU, 1 day on med-surg, and I'm back to work in approximately 2 weeks. Wonderful outcome for me. But I just want to share with you some of the stuff that happened behind the scenes. That's my story, but behind that, 2 to 3 years ago, we started working on a STEMI protocol with the American Heart Association, the Iowa Heart Association. I see Matt Imming up there. He's one of the paramedics that led that charge, so that we would have an agreed upon protocol. And by that I mean that our cardiologist at St. Luke's, the CDA group, it was Dr. Zajac, agreed to follow a certain protocol that we would follow, and our ER doctors would follow, and our paramedics within the ambulance. By doing that, they did not take me to the ER. They took me right to the place that I needed to be to get that artery open. With the heart muscle, time is muscle. With all that going on, I had my artery opened within 101 minutes. And remember, I live 70 minutes from a Cath Lab. So it was pretty amazing. And when I think about it, it was the coordination of all that care, that work done previous to be able to have everyone collaborate and be on the same page. We also have a shared medical record, so that when I'm in that ambulance and seeing that EKG, so is Dr. Feddersen, our ER medical director in our ER unit. So is the interventional cardiologist at St. Luke spontaneously seeing that and saying, yes, we need to go ahead with this protocol now. So I just want you to know that in coordinating care with rural facilities and with senior facilities, you can really save lives, and I'm living proof.
So this is,
I'm just lucky.
so Dawn's story, and forgive me folks, I know we're going a little bit over here, and I promise not to take us too far over, but Dawn's story raises a question in my mind of if you have all these pieces that were working together. I was speaking with some of you before the panel began, and what is happening right now regarding the infrastructure of our health systems, which pieces we do have, whether hospitals close, how that affects rural health clinics and vice versa. How does that, the closure of hospitals, how does that and the other kind of restructuring that could happen, how does that affect workforce and our ability to have the right people in place?
Well, I'll touch on that. Over the last 2 years, many people in this room have been, discussing what is essential, what services are essential to have in our rural communities. And, right now you can kind of put things in categories. What's essential or needed? What do people deserve, and what do people expect? Those are the 3 things. And what's the true answer? It's probably somewhere in the middle. But somebody asked me earlier, said, so what is the future going to be in rural Iowa or rural South Dakota or North Dakota? The first thing that we have to come to an understanding is what essential services, what does that mean? And what services do we need to provide in those communities? it will not be the expected services that have been. There's some things that are going to be different. So we have to agree upon that first, okay? And then we have to figure out a way to pay for that, because we live in a healthcare world right now that can't be made up on volume. There's a cost for available services, and we have to meet those needs. Much like firemen or law enforcement, we have a cost to those available services, and that's what we need reimbursed for. So once we come up with what that looks like, then we have to find the people who want to work in those areas, because not everybody will want to. But it's important to figure out what it's going to look like first and then work off of it from them. That's my thoughts anyway.
I'm just going to add, and at the risk of being redundant, but underscoring Don's story and the need to invest in EMS, training, coordination, strong relationships with rural referral or larger centers. That story, there's not a story that could, there's not data that could better detail the relevance and the importance of the workforce issues associated with needing to make sure we have good emergency services to these rural communities, especially in the communities, as I think you outlined in that question, where we see hospitals either at risk or closing. So I just want to underscore Don's great story.
Okay, let's open it up for your questions. Yes, we have one right here. Let's start up there. Okay, you'll be next.
Hi, thank you for holding this meeting today. My name is Lee Kroll. I'm a pharmacist. I come from Cresco, Iowa, which has a population of about 3,000. I'm currently working at the Carver College of Medicine. I've sat here for over an hour and listened to you all talk about rural resources. There are 900 pharmacies in the state of Iowa, and there are 99 counties. There are at least one pharmacy per county. Where do you all see that pharmacist who has years and years? We have as much training as any advanced practice provider in the country. Why is your pharmacist not doing your chronic disease state management? Why are they not part of your team? Or are they, and you just haven't mentioned them? We have a drug pricing problem. We have folks who aren't compliant with their medications, so they end up in the hospital. Are pharmacists being, are you collaborating with them? And if you're not, and it sounds like maybe you're not, because there's no pharmacist on your panel, why not? We've got the training to do that.
I can speak to that.
Thank you.
Just from our Storm Lake area, we have a transition of care committee. And that talks about transition, whether it's back into the home or if it's in a long-term care facility or a rehab facility. And our pharmacist is on that. In fact, he actually conducts parts of the meeting because the medication regimen and management is so, as you indicate, so important. So I would agree with you, and I think they're more than capable, and they've done great work for us. So
I'm going to add something in. At Avera eCare, we have 130 e-pharmacy sites. Pharmacists are an integral part of everything that we do. In fact, they make me so much smarter and so much safer. So I fully agree with that. I think we've had to have some policy reform around the chronic disease management aspect and who could do that. I don't think anybody disagrees that pharmacy needs to be at that table, and we're just starting to scratch the surface on that integrated delivery process.
Agree wholeheartedly.
Regarding pharmacists, as a practitioner, I talk to pharmacists most every day about medications. There are no pharmacists in Redfield, a town of 800. There haven't been for more than 30 years. The medical practice used to be a dispensing practice, and Iowa did come up with this telemedicine, sort of a satellite pharmacy, but unfortunately there is a startup cost to that. None of that's available because of the cutback on reimbursement for rural health clinics. We also have the 2% sequestration. Yes, we're supposed to get costs, but then you have to subtract 2% because of sequestration. And I agree with that safety net providers should be exempt from that. That's critical access hospitals, that's rural health clinics, that's community health centers. They're essential. And that's a simple way of fixing that problem. And it follows Senator Grassley's principle of having access to care in rural areas.
Let's have the gentleman in the third row here.
Hi, I'm Bill Menner. I'm the president of the Iowa Rural Health Association. I'm also the executive director of the Iowa Rural Development Council, and I'm a rural hospital trustee. So it seems like I spend my days thinking about creating vital rural communities. And Sue, your comments at the beginning kind of caught my attention, because when you think about issues like housing and the environment and recreation and wellness and all the elements that go into making a really great rural place, they sort of align with the social determinants of health. So hospitals are already working on these issues. How is it that we can figure out a way to dovetail the social determinants with vitality and livability and issues like that? And when a hospital is the anchor institution in a small town, they're often leading the charge. So there has to be a way to aggregate our efforts, whether it's economic developers and elected officials and hospital leaders and school leaders, and sort of link arms and walk down the street at the same time singing the same tune. Yeah. So I'm probably preaching to the choir.
Yeah, you are. You are preaching to the choir, and I'll just take a stab at maybe just a comment. You use the word aggregation or aggregators, and I do think it's about more conversation and more communication. And I love the comments from the gal who works in public health, because I think some of the greatest work that I had the opportunity to be a part of in the Fort Dodge region when I was CEO there was working with our public health organization on those issues of social determinants of health and bridging that gap, because from a standpoint of economic development, it's tough to recruit industry to a community when there's not a strong presence of healthcare. Period, end of discussion. So I love that, because I think that is the vitality this conversation needs. I think it's the collaboration we need. Healthcare and policymakers aren't going to solve this without the support of our economic development leaders in our communities.
We have time.
To the choir right back.
Oh, go ahead. We have time for one or two more questions. Or okay, we have one right here.
Hi, I'm Tammy Swenson. I'm an assistant professor at Des Moines University, but I have a question about general access issues within rural areas related to maternal health. And it was kind of highlighted at the beginning in the introduction to the panel about your survey results find that people are having now difficulty getting access to just gynecological exams. I know that you touched on kind of like the issues of essential services versus needed services versus expected services. In that spectrum of issue, I'd just be interested in the panelists kind of commenting on that kind of emerging shortage area within maternal health.
Yeah, and this is what I of course didn't give you all the results of our survey, but nationwide, maternal health came up consistently across rural areas as being a problem with access to care.
I'll answer that question, and I'm going to admit a little bit of, I'm not going to own all of this information, because I actually have an identical twin sister who's an obstetrician, and this is her area of specialty is rural OB crisis management. Couple things. A lot of health systems don't invest in maternity care, in part because of the payment. We've had a global fee in maternity care for 35 years, and it's almost the same today as it was then. When you've got state Medicaid reimbursing $700 for 40 weeks of pregnancy, the delivery, and 18 years of liability, it's really difficult to justify investment in that kind of work. So I do think with respect to rural, what we're seeing is in the heavy litigation environment with a high-risk area where the baby, there are two patients really, and when baby's born, if there's a risk, they immediately need to be flown to a higher level of care. It makes it really difficult for people with a small healthcare facility to want to take that on. On top of which, these local providers are expected to provide the same exact quality of care that you might find in a tertiary or quaternary facility for maternity care. So we have to have a really different discussion with respect to OB. I like to say we got to roll back the bundle, because I think it will shift some investment into that. And not only that, our moms are getting more complicated. They have more medical issues. So again, there's an opportunity to use and leverage technology for things like gestational diabetes management. But at the end of the day, I really think it comes down to many health systems do not want to divert resources into this. And then the last thing I would say is if we can start looking at neonatal intensive care as a possible reflection of what was the care leading up to that point, because we don't want moms to have babies too early, neonatal care is often reimbursed at 90 to 100% through Medicare and through private insurers. It's not to say we shouldn't invest those things, we should, but it is to say if we were able to really focus on this maternal care before baby was born, would we decrease costs because we don't have as many babies in NICUs? I don't know what the answer to that is, but I think there are a lot of good questions to it.
I think that's something we're working on, population as a whole, though. A few years back, you know, the key words were population health management. Somebody mentioned actually this morning, and if you would have told me 10 years ago that we'd be able to even manage the 9,000 people that are in our county, I would have laughed at you because, you know, all those records were, you know, on hard file. But, you know, over the last number of years, we've been able to form committees where we can study our patients and try to be more proactive instead of reactive. And that's really important right now because in the past, our healthcare has always been reactive. And you're talking about being proactive. And we have to keep focusing on that to keep people healthier. The problem is we have a system, a paying system that doesn't pay us for that, okay? We're trying to keep people out of our hospitals and keep people out.
There's no money in doing the stuff that keeps you healthy long term.
Exactly.
And again, it goes back to you have to pay me to think, not to do. So if we're really going to be, if we're going to really bend the cost curve, we have to start when people are babies and look at what are all of the elements of care that you need to have before you even turn 18 years old to be successful. And it's going to hit on those social determinants of health. And it's going to hit on community partnerships where a school and a health system and potentially local religious organizations can support communities in a way that we maybe did 50 years ago, but a little bit differently. So I agree with you. I think we have to start at the beginning. We have to start, you know, for one thing, can electronic health records not have it take so many doggone clicks to just document an immunization? Can we just start with something like that? And I think there's a lot to be said for let's start at the beginning, and in 25 years, we're probably going to see a bend to the cost curve because people will be healthier overall.
One thing people will say is, why, if you have all these expenses that you're putting forth to that and you're not getting paid, why are you doing that then? Because what we found out over the last 3 to 5 years is because it makes sense. And it keeps people healthier, and it keeps people out of our emergency room. Oh, by the way, that's how we get paid, by having them in there, right? So that's why it's not working. That's why it's got to be fixed.
Okay, we're going to squeeze in one last question, a speed question, the gentleman all the way in the back.
One of the things that when I look at it, as a state, we are heavily dependent on people or physicians who are trained out of state to come and serve here. Let's take the example of my specialty, cardiology. We have 2 training programs in state for cardiology, one at the University of Iowa, one I think in Mason City that I'm not very familiar with. As on date, there are 17 cardiology trainees at the University of Iowa Fellowship Program, of which only 3 have went to the University of Iowa for med school. Rest, everyone is from out of state who's coming and training there. Of these 17, I think 12 of them are from outside of the United States. They came, did their residency here, and they are now training as fellowship because the fellowship recruitment is based heavily on merit. You know, you have to be really good. That's how you get selected. So people outsmart each other and get it there. Now, let's imagine these people are graduating. Of these 17 in the next 3 years from University of Iowa, how many are going to stay in Iowa? Well, 12 of them don't, you know, they can go anywhere. Of the 3 that are from Iowa, will they stay here? We don't know. So how can we make it more, you know, something that we can invite them, hey, stay here, this is a good place to practice. there are a lot of thinking to be done regarding this. In my practice, we've been struggling to recruit people. We have people retiring, but we can't find people to fill in because we can't have anybody from outside to come here. When I finished my training and I said to everyone in my program, hey, I'm going to Des Moines, Iowa, they were like surprised. Why are you going there? You know? So we kind of have to make this more, more palatable to people. Hey, come here. This is a good place to practice. Or we develop more training positions in Iowa. We can have a fellowship program here at Iowa Heart, at Unity Point. We have the resources, but we don't have funding to start new training programs. Okay? And we can also do this, like, hey, if you want to be a fellow and train here, well, you have to put so many years here at Iowa after you finish. We can, some sort of binding commitment on people who train here, hey, you have to serve the state. Without that, this problem is going to, we love our pork. Everybody, we have a burden of cardiac issues here, but we don't have enough people to serve. So I think we have to make this a little bit more, how can we get more people in here? And that's how I brought up the previous question was a lot of physicians who train in cardiology and other practices, fellowships, are foreign graduates who came here, trained and did their residencies and are now getting into the job market. How can we invite them to be here? So that's where I think we have to focus on, because it's not easy to just start building up programs. It takes a lot of funding. So the people who train, how can we get them to Iowa and stay here? I think that should be our focus.
Does anybody have the silver bullet answer?
I don't think I have a silver bullet answer, but a couple things. I think you talk about cardiology and the number of people who grew up in Iowa staying and practicing in Iowa. As far as I know, one of the most critical specialties right now is cardiothoracic medicine. We have a lot of people who are retiring. And so when we talk about this rural health piece, then we also have to sort of understand in terms of our physician workforce how fewer beds in the communities are going to stress and put pressure on the larger facilities. And you can see it happening in the subspecialty care. So in our case in Sioux Falls, we recently had our first female cardiothoracic surgeon start just about a week ago. And it was really a collaboration with the Mayo Clinic. So collaborations with community-based facilities where residents have the chance to get higher volumes and practice higher volumes, I think is a part of that issue. The other consideration, and I wouldn't want to water this down, but when you're in these large academic training centers, there's such a focus on research. And it's not to say that we should stop doing that, but there isn't a focus on returning into communities to serve your local population. And so to answer the question of why are you going to Des Moines, it's a great place to work. The Midwest is a wonderful place to be a physician, but you are going to be leaving that academic merit-based place. And so I think the medical schools and certainly our universities can begin to have conversations about community service, about doing rotations in those local facilities, and certainly looking at some possible opportunities for people who are from the state of Iowa, in Iowa, to say, if you can dedicate some time back to us, could we potentially save a slot for you in our program?
Let's thank Marilyn and her panelists for their presentations this afternoon. And I want to thank you, the audience. I know we've run a little bit over what we had planned. I want to particularly thank Unity Point and Sabra and Ashley. The staff knows that I have a particular interest in this. I grew up on a small farm over here in Indiana. In fact, was at the farm over the weekend and drove over here yesterday from Indiana to be here with this event today. But on a one trip back many years ago to the farm, my wife had a serious medical issue that required surgery, and the nearest hospital was nearly 45, 50 miles away. The surgeon was from Mexico, and in fact, to the gentleman's point back here, I think he was here under something called the Conrad Waiver Program. More importantly and more recently, on my birth of my first grandson, my daughter-in-law was having problems in Taos, New Mexico. And she was flown from Taos, New Mexico on a helicopter, emergency helicopter, to St. Presbyterian in Albuquerque. The cost of that medical evacuation was $60,000. I asked my son, I think you've got the decimal point in the wrong place, and he showed me the bill, and it was not out of line. We were lucky. We were able to work this out. These are real issues that we are confronting. Thank you for the panelists. Thank you for your questions. These are things that we will be taking into consideration as we work through this. Rural and frontier folks deserve the same access to and quality of care that many of us take for granted in urban areas. Thank you for your attentiveness this afternoon. Have a good day.